Everybody hear me? Right. Great. So thank you so much for the opportunity to come and present the research that I've been doing during my PhD. So I've worked at the Norwegian Directorate of Health since 2011, but since 2017 I've been doing research in this public sector PhD project, which is a collaboration between the Norwegian Directorate of Health and the University of Oslo. Before I start, I would just like to ask how many in this audience are not from Norway? Because this is interesting for me. Right, okay, so it's a good, it's a little month. Oh, so the background for my project was we have from 2015 in Norway a revised national guideline on food and meals in schools. And the following year, there were lots of implementation conferences around the country where my colleague traveled all around and talked to people and introduced these guidelines. And we were wondering, were these guidelines then put into use? And if not, what would it take to put them into use? There was also a report from the Auditor General that was published in 2013, which formed part of the background for this project, because they had assessed the effectiveness of the work of the Norwegian Directorate of Health. And they had found that we were not working systematically with implementation of our guidelines and other normative products. In fact, when they looked at all the reports or the normative products from 2009 and 2010, they found that 2/3 of these products did not have an implementation plan. And furthermore, another report came from the Auditor General in 2015 when they reviewed the public health efforts at local level. And in this report, they identified several weaknesses with the local public health work, and they pointed to the need to do more intersectoral work to promote public health. And in the same report, the municipalities and counties had called for, these were interviews, they had called for more information about effective interventions. What could they do at local level to promote public health? So since there are lots of people here who are not from Norway, I included this slide on the Norwegian school meal context. We've already heard a little bit about it. So you all know now that there is not currently any national school meal scheme. In primary schools, there is still the packed lunch model. However, the Norwegian municipalities all have an obligation to offer an after-school service for the youngest children, so children in grades 1 through 4. And most of these services, they do serve an afternoon meal. So there is some degree of food provision in Norwegian schools as of today. In lower secondary schools and in upper secondary schools, there's still both a packed lunch model common, and many of these schools also have a canteen where the students can buy their lunch. So in Norway, we have had advice on school food since the 1970s in different versions. And the previous guideline, which was published in 2003, lasted until this revision in 2015. The 2003 guideline was very short and general. It was a poster with brief points on time to eat, supervision, access to clean drinking water, and then some points about what schools should and should not offer. However, it was just one poster covering the different school types. So in the revision process in 2015, it was clear that there was a desire to have recommendations specified for the different school types. And in these, the guideline has 3 parts. So you can see them here, the primary schools and the after-school service at the top, the lower secondary school and the higher secondary school. And each of the recommendations contained in these guidelines have a part where the evidence is laid out, an elaborative text about the recommendation, and also practical advice on how to implement. And this guideline recognizes the potential role of meals in schools in reducing social inequality in diet. It also recognizes the importance of school-based policies to work on school meals. Also the collaboration with parents and student participation in any work to do with school meals. And all these parts of the guideline have 4 main areas that relate to the physical and social eating environment, nutritional quality of foods and drinks, food safety and hygiene, and environmental considerations. And these last two aspects were new for this 2015 guideline. And what's the regulatory basis? Well, we have a pretty, I would say, strong Public Health Act in Norway as of 2012, which states that all municipalities must work systematically to promote and protect health with all the means available at the municipal level. And the obligation to promote and protect the health of children is further elaborated on in this regulation on environmental health in kindergartens and schools, which states that nutritional quality of meals and the social functions of school meals should be ensured. And in this regulation, they make explicit reference to the national guideline on meals in schools. Furthermore, we have the Education Act, which states that all pupils are entitled to a good physical and psychosocial environment conducive to health, well-being, and learning. However, there is no further operationalization of what this means in terms of school meals. And then there's the Food Act, of course, relating to everything to do with food serving and food handling, and all those provisions must be complied with. But so are these guidelines voluntary to follow? I would say no. We have this regulatory basis, and even though it's not so explicit on exactly the obligation, I think that if we take the approach in the regulation on environmental health, we can say that on the par with that, if schools choose to follow practices that diverge from the authorities' recommendations, then they should be able to explain and document why they do it, and that their practice is as good or better than what the health authorities recommend. So in my project, I have taken implementation science as the theoretical approach. And this is a rather recent research discipline, which is rooted in the recognition that effective practices have limited impact unless they are well implemented. Implementation science aims to bridge the gap between research and practice. And one of the common statements or reference is to these studies showing that it takes a very long time between an innovation being shown to be effective in a hospital setting, for example, a treatment, and until it's become routine practice in the hospital. So there's a long time lapse. And the roots of implementation science is from several disciplines, but there are clear links to the evidence-based medicine approach and also early diffusion work. Some of you might have heard of Everett Rogers and the book, The Diffusion of Innovations. So I like this model, which is a way to illustrate the implementation gap. And this was proposed by Greenhalgh and colleagues in 2004, where they tried to explain the difference, the different stages of implementation, so to speak. So to the left here, where it says diffusion, this is where you let things happen. For example, if you have a campaign to increase fruit and vegetable consumption, you use social media and you reach the very motivated receivers. However, in the next stage, which we can call dissemination, you help it happen. You, for example, send out a national guideline to all the schools in the country and you hope that they put it into use. And then the last stage here is real implementation as it's being used in implementation science. And that's you need to have a much more active strategy here to make things happen. And it usually requires a dialogue between researchers and practitioners. So just briefly, within implementation science, there's an overwhelming number of studies now, but as I said, the first, it's a rather recent research discipline in its own. Its first scientific journal, Implementation Science, came only, I think, in 2012, or was it 2006? Anyway, in the last 10, 15 years, it's really grown. And these are the major research areas. Determinants of implementation, so barriers and facilitators of practice, implementation strategies and drivers, how to measure the implementation outcomes as distinct from intervention outcomes, and finally, scaling up and sustainability issues. And so this is the thesis that I'm working on to finish currently. Its title is Promoting Public Health Through Implementation of School Meal Guidelines. And I'll tell you a little bit about my studies, but not in much detail. So the first part was to develop questionnaires to measure guideline adherence. And the brief background is, of course, that to be able to talk about implementation and changes in implementation, you need to know at what level roughly the schools are, like at what level are they currently operating vis-a-vis the national guideline. But there is also a longer background. We have in Norway had a regular mapping surveys of meal practices conducted since the 90s, like every 6 years perhaps. They have, however, been quite comprehensive, covering organizational aspects, competencies, finances, food provision, etc. And they're valuable because we can follow selected indicators over time. For example, time to eat, supervision, food provision, etc. But none of those previous mapping surveys have said anything about adherence or compliance to the guideline, to the current guideline overall. And validity and reliability has never been tested before in those surveys. And we saw in the last survey in 2013 that there was a quite low response rate, around 32% of schools replied when we sent it to all the schools in the country. And the 2013 surveys also showed very large variation in practices between schools and also very low awareness of the national guideline. But in terms of practices, for example, there was a low proportion of schools, roughly 40% of principals who said that children in his or her school had 20 minutes time to eat. And in the after-school service, around 20% said that they served vegetables daily with the afternoon meal. So the objective of this study was to develop valid and reliable questionnaires to measure guideline adherence in primary school and the after-school service. And this is what we did. We followed a quite comprehensive approach to develop questionnaires, where we started, of course, with the previous questionnaires available, defined scope, questions, and adherence cutoff levels. And then we had it for expert review to improve its face validity, which refers to whether the questionnaire appears to measure what it intends to measure. And then we did 2 rounds of pre-testing through cognitive interviewing. Cognitive interviewing was new to me and a very interesting technique designed exactly for the purpose to improve questionnaires in terms of wording, response options, etc. So that's the content validity, to check that we cover all the relevant aspects and the comprehensiveness. So after that, we tested it for the 2 questionnaires for reliability in a test-retest study where we had around 50 principals and 50 after-school leaders reply to the same questionnaire twice to see to what extent were they able to report on their meal practices at 2 time points, 8 to 10 days apart. And what we found and write about in this article is that cognitive interviewing with the target groups increased content validity through improved relevance, wording, and user-friendliness. The test-retest study showed that both questionnaires had acceptable reliability. For those of you who've done this, you know the kappa, the reliability parameter measuring kappa values and the percent agreement and intra-class correlation. And all of these 3 showed that these questionnaires can be used in evaluation and research purpose for those purposes. Also, the response time that people spent answering to these questionnaires was acceptable, around 12 or 11 or 12 minutes for the school questionnaire and a little bit more, maybe 14 minutes for the after-school questionnaire. The questionnaires had about half of the items of the previous big mapping surveys. And the adherence levels that we identified in this test-retest study showed that during school hours, the meal practices adhere roughly 71%. However, as you can see here, there's a very wide variety, a wide range in what the adherence level was at, between around 40% and upper 90s. So we can see that the questionnaires were able to capture a wide variety of meal practices, both in the school and in the after-school service. My second study is about implementation barriers and facilitators, and this was also a formative study intended to inform the implementation trial that I will get to next. So what we did here, this was a purely qualitative study. We went to 4 different schools in Hedmark and Oppland counties, not so far from Oslo. And we conducted individual interviews with the school principals and with the after-school leaders, and focus group interviews with groups of students or pupils and groups of class teachers. So altogether, we had 61 participants, of which 26 were children, and these were from grades 1 through 4. We wanted to have not a too wide age range in these focus group interviews. And then the groups of teachers were comprised by the teachers from the whole, like 1st to 7th grade, to be able to capture variety in classroom practices across a broader range of age groups. So in this study, we took a deductive approach. We know that in implementation science, there's a lot of different determinant frameworks that are being used. And so we reviewed several of those and found out this multi-level quality implementation framework was the best fit for us. This was developed by Domitrovic and colleagues. And this is a type of an ecological model where you see there are 3 different levels here that we try to capture different constructs for. Ecological models, they are usually intended to find determinants in order to develop environmental interventions. And these interviews were transcribed and analyzed, so we interviewed according to all these constructs. We had 4 different interview guides, and we analyzed this in vivo according also to these constructs. And so it's very difficult for me to summarize these findings because they were so wide and there were so many different aspects. But overall, we did identify both barriers and facilitators at all these different levels. More barriers than facilitators, and most of them centered around the school level factors. But very briefly, at the top here, very many teachers and also principals said that there is a very weak mandate to prioritize work on school meals. There's no direction from higher administrative levels, and it seems quite voluntary to deal with these guidelines. So that was it. And an interesting facilitator was the engagement by the education authorities. Actually, at 3 of the schools, teachers and or the principal mentioned a letter that has been sent by the Ministry of Education and Ministry of Health jointly in 2017 to encourage all school leaders to ensure that children had enough time to eat. And this had really made an impression. When it came directly from the Ministry of Education, the school leaders at municipal level really listen, right? At the school level, it was clear that the teachers felt oftentimes that the principals were not so invested. They felt there was a weak administrative leadership in the area of school meals. I think an example of that, which is illustrative, is the fact that none of the teachers that we talked to, so maybe around 28 teachers, none of them had heard of the national guideline, whereas 3 out of 4 principals and half of the after-school leaders knew about the guidelines. So in very many cases, unfortunately, the guideline doesn't really reach out at school to reach the teachers. Yeah, there was a lack of a school culture around meal practices, showing very very different practices from classroom to classroom in terms of hand washing, access to drink. Were they allowed to drink during class? What they could bring into school, what was acceptable and what was not. Also, I have to mention the noisy classroom climate, which was identified and talked about by so many teachers that, this is what they talked about when I asked, why do you put on a screen? Why do you carry out educational activities during the lunch hour? Oh yeah, it's so noisy. They said we have to try to promote peace and quiet. And so a no-talk policy was pretty common in these classrooms where children were actually not allowed to talk. They weren't allowed to move to a different table. They had to sit at their desk and eat their food in silence. Often, you've also observed that lights are dimmed, so it's like a cozy, dark, quiet environment. And there's a screen on the wall. For me, it's very strange. It was not like that when I was a child. And just to look a little bit further into this, we saw that there were some areas of the guideline that were particularly difficult to implement, or that they talked a lot about at these schools. And it was in relation to the recommendation to promote social and enjoyable meals, to provide at least 20 minutes to eat, and the foods brought to school from the homes. And these were the exact same topics that the children talked the most about. They talked a lot about this, that they didn't have time to eat, that they couldn't sit with their friends, that it wasn't social. They wanted to talk. And when we look closer at this and analyzed, we saw we pulled out two factors that we think are underlying explanations, and it's that school meals are not a priority currently, and there's a lack of authority at school level to implement, linked with that lack of direction from higher levels. Okay, and then this is the last study. It's an implementation intervention to increase guideline adherence. Based on all we had learned, we wanted to do our best attempt to try to increase guideline adherence in this trial. And this is called the Food Ambassador Study. And before I go further, I would like to ask if anyone has seen this abbreviation before in relation to intervention development. I've seen it at least two places, in one book and in one article. I will let you know. It's called, "It Seemed Like a Good Idea at the Time." And this, as I've understood, when people or researchers are very busy, this is often what happens. They don't have time to really go into the details of theory, but we did our best to really try to anchor this in theory. So in implementation science, there are lots of different approaches to talk about factors that accelerate implementation. And this is one big implementation science research group in the west of the USA, Chapel Hill, I think, for the American here, Fixton and colleagues. They have suggested this concept of implementation drivers and core components. And this is their active implementation drivers model, where they say that a lot of the factors that are important can be summarized according to these three axes. So the competency drivers, organizational drivers, and leadership drivers. And there are several core components within each of these axes. And they are integrated and they can compensate for another, but you have to make sure that you address these three axes of drivers. And so we did, of course. An example of a component here is coaching or training, for example. And then, for fun, I added this formula for implementation success, which comes from the same research group in the US. So this formula for success can be added on to this implementation drivers model to make this great picture. And I will read it for you. I will try to point maybe at this. Let's see if this works. No, it's a little difficult. I was going to help you look at the picture to the right when I read this formula, because it fits quite nicely. Populations benefit, so at the top here, socially significant outcomes, when effective innovations, down to the left, are supported by effective implementation, at the top, in enabling contexts that facilitate the use of these innovations on a socially significant scale. And so what this also shows is that both the innovation, so in my case, that would be the guideline, and the implementation have to be carried out with fidelity, so that you do what you're supposed to do. I mean, so it's done properly or with quality. There are other terms for this. There has to be capacity for change, and there has to be a supportive policy environment for change. But then another approach in these implementation drivers and components is the term implementation strategies, and this has really taken over, I think, in the research field of implementation science. Implementation strategies can be defined as methods or techniques used to enhance the adoption, implementation, and sustainability of a clinical program or practice. You will see in almost any definition of this that implementation science comes from medicine. Like, it's always about clinical program or practice, but some also highlight that this is applicable across disciplines. And I wanted to show you this example from the ERIC study. This is called ERIC for Expert Recommendations for Implementing Change. This was based on the frustration that this relatively new science field has very different terminology. So they wanted to tidy up. They refined and defined 73 discrete implementation strategies through a Delphi process. And then in step 2, they used concept mapping to rate these different implementation strategies' relative importance and feasibility in this big picture here. And in quadrant 1, so the green one, is where the strategies with the relative highest feasibility and importance are placed. So this was also just to say that, of course, we made sure that we were within this green, quadrant when we planned our study. So this is the Food Ambassador study. The research aims were to develop strategies and tools to increase guideline implementation, and then to evaluate effectiveness of the implementation intervention and to assess important implementation dimensions. And I'll get back to what those dimensions are. This was a non-randomized controlled trial. And a part of the reason for that is that we were able to collaborate with two ladies who sit up here, who come from a county in Norway, south of Oslo, who had initiated a large public health project in their county, Østfold. It can be abbreviated to the MOVE project in English. It's about increasing physical activity, healthy diet, and sleep habits among all school children in their county. And so we randomly met and talked about what we were working on and decided that we would collaborate, because I had now already developed tools to measure guideline adherence, which they needed, and I needed a place to carry out an intervention. And they had not yet done much on the dietary part in that group of their project, who were part of their project. So this food ambassador study would be responsible to carry out the dietary component of that project in the fall of 2019. So we were able to recruit 33 intervention schools from that county, and then we recruited 34 comparison schools from the county of Buskerud, which is on the other side of Oslo, but comparable in size and comparable on many public health indicators. And so the main implementation strategy was internal facilitation through the use of food ambassadors as change agents at their own schools. And this is the logic model of the project. I'm not going to go through all of this, but talk about the parts in bold here. So using the terminology of implementation science, the innovation in this case is the guideline. It's right, it's already there. I'm not really going to change it. That's the innovation, but I'm going to try to implement it better in the schools. So the implementation strategies that we chose were information meeting, or it's also called educational meeting, where we gathered all of the target groups, the principal and the after-school leader and the teacher at these intervention schools. We carried out training sessions for the food ambassadors, which were these appointed teachers by the principals, and the after-school leaders. And then the internal facilitation by the food ambassadors was really in terms of them going back to their school after training and carrying out workshops 2 times. One time with their colleagues at the school, so the class teachers, and one time with all the after-school care staff. And then they would develop action plans on what to do next. And the implementation outcomes, this is what I refer to as implementation dimensions. So I measured 4 dimensions: fidelity to the intervention, dose of intervention components received, that's really like how much were they present and attending the different trainings, and did they receive what we intended them to receive. Quality of intervention delivery, and participant responsiveness, which measures engagement and involvement by the participants in the study. And then the intervention outcome was the guideline adherence at school and after school service. So we measured that before and after the intervention. And of course, a major limitation of the study is that we did not have data on child outcomes. This was a school-level study. So there's an assumed link here between increasing the guideline adherence at school level and that influencing outcomes in children. And I think that we could probably, based on your this morning, say that it's likely that in many ways, for example, if you change cooking oils in the after-school service, automatically children improve their diet, right? So, but it should be established. So these were the activities and tools in the Food Ambassador study. There was an educational meeting first, then training of the food ambassadors and the after-school leaders, and then the workshops that the food ambassadors were going to carry out. You can see some pictures here at the top right, where the workshop model was, it was 1.5 hours that they had to collect all of the class teachers at their school with the support of the principal, and first go through, well, there was a presentation about, you know, school food, then a checklist that everybody individually would fill out. Do we adhere to this recommendation? This was to make them familiar also with all the recommendations out at the schools. And then they would, in group settings, discuss with the help of this guide. This was a guide which stated the recommendation, gave the rationale, and then some facts about status, what was the status for this, and then the reflective questions on really trying to ask, well, are you following this recommendation? Do you do this, or review this, because it's very quick when you see a checklist, but yep, we provide 20 minutes, yes, we do this, yes, we do this. But so these reflective questions, I think, changed maybe some of their initial impression. And then they made an action plan that they had to send to us. And then lastly, the last training in November, we created collaboratively these information materials meant for communication with parents about school meals, why they are important, and advice on how the packed lunch may look like, and trying to go beyond the bread-based packed lunch model. Very briefly, on the flow chart here, we can just see that we lost two, let's see, we lost, can I do this? No, it doesn't work. Two schools in the intervention county, and we lost 6 schools in the comparison county at follow-up. And we were lucky to be able to complete this study just before Corona hit. It was like February something that we received the last responses. And so I'm not going to give you all the numbers in the results from this study, because this has not yet been published. But you can see here the baseline values for adherence in these 2 counties was quite similar. They were not statistically different, but you can see that the intervention county was a little lower at baseline. And again, like we saw in the test-retest study, there's a very wide range in adherence level among the schools in these 2 counties. So at follow-up, we saw a significant difference in change scores. So we measured that by looking at the adherence after the intervention minus the adherence before the intervention. So there was a significant difference between them, both unadjusted in a t-test and when we adjusted for baseline adherence values. Perhaps surprisingly, school socioeconomic profile was not correlated either with the baseline adherence value nor with the change scores. However, when we looked closer at the data, there appeared to be an interaction between having a a low baseline adherence and achieving a large change score from the intervention. And this was seen in both the counties. I mean, there was a tendency also in the comparison county of this. And so you have this interaction, and we controlled for that to look at the results, and the difference remained. I'm not going to go through all of these, but so these relate to some of the recommendations that we were able to see a change in when we measured the scores after the intervention. However, at the bottom, you see that the one we were not able to do anything about among the intervention schools was this, to promote social and enjoyable school meals. There was like 0 change, and we don't understand why, because we really made an effort to talk about the importance of social school meals, not using a screen and all this. And there were also several changes in the after-school setting. In terms of the implementation outcomes, these are, so now this might be confusing, because here there are, instead of 4 dimensions, there are 6, but that's because 2 of them were split. Dosage was the one that was the highest. It received the highest score. We created index scores here again. So that means that really all schools showed up for the trainings and for the activities. And engagement was the lowest. So among these dimensions or implementation outcomes, it was school level fidelity that correlated the highest with the change scores. School level fidelity really measured, I think it was 11 variables, and reflects the participation by the principal in supporting the intervention, that the principal was supportive, helping out, collecting teachers to join, following up, basically. And we also, in an exploratory model, tested whether school level fidelity could predict improved adherence, and it turned out to be a pretty good predictor. Okay, so I tried to collect the discussion and implications from these 3 studies in this little summary at the end. So the question is the national guideline implementable? Yes, I think so. From the qualitative study, we heard from very many that they held favorable perceptions of the guideline. They found it a useful reference point. The teachers said it's very useful for us now to know about this in terms of communicating with parents, because they've had nothing to refer to that they were aware of. The guideline supports the mission of schools. This was an impression clearly communicated by the principals, all of them. They said, that clearly meals in schools can contribute to reduce the social inequalities in children's diets. And also they highlighted the role of school meals in promoting a conducive learning environment. Through the interviews, both the cognitive interviews and the other interviews, it's clear that we can develop, like share common language between health and education sectors for school meals, but we do need to talk together because we do use different terms and terminology and have some different opinions. So we need to talk together, but it's possible and it's important. And is the guideline measurable? Yes, clearly. The study one showed that the reliability parameters showed that the questionnaires are suitable both for evaluation and research purposes. And I think that the wide range in adherence levels across these schools also illustrate that we're able to map or to monitor the adherence levels across a whole range of practice scores. What may be done to increase guideline implementation? Well, I think at national level, it's clear that we need a clear mandate to implement the guidelines by the educational authorities. We need to communicate that there is a mission policy alignment here, that the mission of schools completely is consistent with the intent and content of the guideline. We need to communicate that implementation is not voluntary. It's a misperception that exists many places. However, we also need to provide much more implementation support. Step one is to increase awareness. When so many schools and teachers particularly don't even know that there are national guidelines in this area, we need to make sure that more of them are aware. And I think there is something around talking about this problem of why is it so difficult to promote social and enjoyable school meals? And in the interviews, we heard about some municipalities saying that, well, the break, the time of the break is not protected, so it's up to the teachers to find the time from class before or after. So some children have 10 minutes to eat, others have 20 or 30. But in some municipalities, they have defined that the time to eat need to be educational time. And then teachers feel that they have to fill this lunch break with educational content. So maybe educational movies, or even like some are doing homework. I mean, you hear different things. But anyway, we need to talk about this and maybe find an agreement that even though the time is defined as educational, it's pretty educational to have social school meals. They have other benefits, or many benefits. We need to provide information material on healthy packed lunches as a tool to support teachers. They really called for this. And I think that we need to strengthen the role of the school health service in supporting the work on school meals. So the teachers said, that they don't feel credible when it comes to nutrition and health. They don't have that education, and they have to stand up front and talk to the parents about this. Why maybe not bring cake every day? Don't bring, sweetened drinks to school, which a lot of children do, and it varies between classroom and classroom. So they need, the teachers would like more support from the school health service in this. And also I think that the school health service needs then to have access to nutrition competence, which also is rather low in many Norwegian municipalities. There are some that have nutritionists, but not so many yet. At municipal level, there's a lot that can be done to raise awareness and also to engage in implementation activities. We have to remember and communicate that the school principal's engagement is essential to make any type of change. They can, at the municipal level, to a much larger extent than today, monitor and enforce these guidelines. They have already the mechanism through the regulation on environmental health. They could include aspects of the school meal beyond food safety, which I know that they already do inspections on. They can apply nutrition standards in procurement, and the Norwegian Directorate of Health has guidelines or guidance on this already. I think that we can easily communicate that to ensure that for example, after-school leaders talk and meet on this topic. We really should ensure that there is more uniform practices between, for example, neighboring schools in the same municipality. You can find really different practices, which to me is a big paradox in this, that if the child goes there or there, it really, it's so random what meal practices are followed. Schools themselves should probably sit down and write a meal policy at school level if they have not already done so. They can conduct activities to promote a culture around meal practices, much the same as the above, for example, through the workshop model or other similar activities. But the most important thing is to put this topic on the agenda and let actually the whole school or all the teachers talk about this. It was such a common feedback after the qualitative interviews that this was so useful to sit for 1.5 hours and talk to my colleagues about this, because they are alone in the classroom and confronted with all these situations, and they really enjoyed talking about it. Just hadn't done it before. To involve the school health service more, a teacher in food and health, and the student council in anything to do with meal organization and implementation. To have proactive communication with parents about packed food, then they avoid many of these unlucky situations where the teacher is standing there and trying to defend, what is healthy and define is the snack bar appropriate or is it actually not. It's difficult. And they can also participate in the national competency programs available, Fiskesprell, Matjunglen, etc. And then very briefly, I'm not going to go through all this, I think, but how can meal practices be monitored and enforced? There are two main, maybe types of approaches. One is the guideline adherence monitoring that I've done through my project, but then the much more common way is to do self-assessment tools, like in Sweden. They have Skolmat Sverige, School Food Sweden, which is a different approach where there are lots of different practices. You can do one module or all of them. So there are benefits and disadvantages to both. The ideal is probably to have both, but probably not very feasible because the questions have to be formulated differently, right? If you do guideline adherence monitoring like we did, you shouldn't be so upfront. What are the thresholds here? Because then you risk the social desirability responding to be just within adherence. Whereas in a self-assessment tool, maybe it's almost the purpose to actually guide the schools when they do this to see. You should maybe, this is the threshold, this is good enough. It doesn't matter so much if you are upfront what is the good enough practice. So anyway, whatever system we use, tailored feedback on current practices is shown to be an effective strategy for improvement work. So this might be the most important function in any case, whatever system you use. So last slide, implications of this project. For policy and practice, I think that we have learned a lot about the strengths and weaknesses of the current guideline, which will be useful for a future revision process, whenever that will be. We know more about the most difficult areas for the schools to implement, and we can use this so we can target implementation support to the most difficult areas. We also have now more insight into adherence monitoring, which we can use for whatever system we want to develop. And if a new school meal scheme is introduced, and it was very promising, the words we heard this morning, we know now more about important implementation aspects that we need to consider if school meal reform is really going to take place. In terms of research, it would be beneficial, of course, to do some further validation of the questionnaires, and also to do inter-rater reliability testing so that you have, for example, the principal and the assistant principal or a teacher, that both of them reply, and let's see if they are responding the same way about their school practices. There is, of course, the problem that the principals don't always know what's going on in the classrooms. Further testing, very importantly, how to overcome barriers to social and enjoyable meals. I think we will be hearing more about it at this conference, so I'm very excited about that. I wasn't able to go so deeply into it. Further testing of the food ambassador intervention would be advantageous, of course. See if results are replicated. And finally, it would be great to have effectiveness established of guideline implementation on child outcomes, because this is what people will ask. Well, does it matter? Does it matter on a child level? I think so, but it really would be helpful to have measured that. And then this is all the people that have worked with me on my project. So my co-authors listed above. And here I have mentioned Elsie Brenna and Katrine Gundersen, who are here from the county of Østfold, and also my colleague at the Directorate of Health, Eva Rystad Brisis, who helped me out with the intervention program. And funding from the Research Council, and also the Directors of Health through paying my salary. Thank you very much.